Welcome, everybody. We're glad to have you here today. Thank you for joining us for this, what's going to be a great conversation with Dr. Vergare from Jefferson Health and Will Crowley from NeuroFlow. I'd like to invite you to start by telling us where you're from. Go ahead and give us your name and your organization, the city you're in. We'd love to hear more about you. Love to be able to know who our audience is and who we're talking with today. Let's go ahead and look at the agenda. We're pleased to be joined today by our sponsor, NeuroFlow, and Dr. Vergare from Jefferson. We'll be hearing a little bit from both of them today, and then we'll have a good portion of our conversation will be dedicated to Q&A and to a discussion. And then I'm going to start off, though, by kicking off, telling you a little bit about the ACLC for anybody who's new, who hasn't joined us on these conversations before. The ACLC is the Accountable Care Learning Collaborative, and it's our mission to accelerate the success of organizations in value-based payment models. And we were founded by former Secretary Mike Levitt of HHS and his former CMS Administrator, Dr. McClellan, for this purpose. And we've gone to great lengths with industry to identify competencies in succeeding in value-based care. And we're going to talk about one of those competencies today. And you can reference the list of competencies online at the Accountable Care Atlas. And today we're having a peer learning session about one of these competencies. We'll be discussing behavioral health today. And we'd invite you to put your questions in the chat. We expect a fairly robust group today, so we'll definitely be looking at chat for questions and for comments. And we want to invite you to share your screen and to be part of the conversation as we get moving. As you know, when we open up the Q&A after the presentation. And this is meant to be a conversation, a discussion, an opportunity for peers to share thoughts and share mindsets around important topics that we need in our value-based adoption and our value-based programs. So with that, I'm going to ask you a question to think about during the presentation. And it's, what is your organization doing to identify and manage patients who need a collaborative care model for behavioral health? And Dr. Vergare is going to talk a little bit more about this today, but just have this question planted in your mind, and we welcome you to share your thoughts in the chat during the presentation, as well as during the Q&A. And with that, I'm going to give Will a couple minutes. We're super grateful to NeuroFlow for bringing this case study together, introducing us to Dr. Vergare, and helping us understand this important story.
Great, thanks, Dan. Hi, everyone. My name is Will Crowley. I'm the Director of Marketing at NeuroFlow. Thanks so much to the ACLC for helping us put this together this session to showcase the great impact that Jefferson's making due to their forward-thinking approach to behavioral health integration. And before Dr. Vergare discusses our partnership with Jefferson and NeuroFlow, I just wanted to provide a quick overview of what we do at NeuroFlow to give some additional context for the case study that we'll be going through. Now, NeuroFlow brings together technology and services to remotely engage and support patients around their behavioral health while helping organizations make the transition towards integrative collaborative care. And we combine a HIPAA-compliant care team dashboard, an award-winning mobile experience for digital self-care, and a robust catalog of care services, and helping make NeuroFlow a leading enterprise-grade solution for behavioral health integration. Really excited to share how we've worked hand in hand with Jefferson to transform their approach to behavioral health, and look forward to discussion and questions later in the session. I'll hand it over to Dr. Vergare now to kick things off.
Well, welcome everyone today, and thank you for participating in this session. And I'm honored to be able to speak to you about something that has been within the field of mental health for decades, but is only finding new pathways to bring behavioral health to the primary care front. Our history with NeuroFlow started around some of the things that Will has already mentioned, and that is we needed a way to screen our population to determine the level of risk that individuals in our primary care practices face for mental health and substance use issues, And then we needed to develop care plans that were realistic and supportable without a vast increase in staffing. And our first conversation with them evolved around postpartum depression, but it has gone much further since then. But let me step back and first tell you a little bit about Jefferson itself. Like so many hospital university systems around the country, we've been through a lot of change going back to around 2014, 2015, when we started to take steps to bring our own small system, two hospital system, back together and reunite the university and education platforms with the clinical care platforms. And that happened under some dynamic leadership, new CEO, Dr. Stephen Klasko, who was also very committed to looking at value-based care and committed to including behavioral health interventions in some way in that kind of organization. We quickly grew during that time. And in 2014, we added another regional health system, the Abington Health System, followed by another system that covered another part of Philadelphia. And then by 2017, an additional organization, the Kennedy Health System in New Jersey, bringing our total hospital campuses to 14. So we rapidly grew from 2 campuses to 14 campuses, just under 1,000 inpatient beds. And just yesterday afternoon, we finished our merger with yet another behavioral health system with 3 additional campuses, the Einstein Healthcare Network. And while a lot of the focus was about hospital-based care, feeding this entire network was a range of diverse primary care practices. And those practices were also operating under, and still are, under different electronic medical record umbrellas and are slowly merging together into a more unified entity with more consistent pathways for care. But in the background, each of these campuses had different initiatives going with value-based care. Philadelphia still remains a rather traditional system. There's a lot of fee-for-service activity. Very few of us are really under a fully integrated and capitated model of care. And so it's a little surprising, but we're not where we thought we would be in 10 years ago, which would have been a model that would be fully integrated and incentivized for care. Nevertheless, at the value side of things, we remain committed to doing things in the most efficient way and then also bringing specialty care together with primary care. As I had mentioned, Neuroflow, which is based in Philadelphia, approached us to say that they thought they could help us with identifying depression in the postpartum period and the prenatal period. And we started to work on that, but also in the background, we were engaged in the CPC Plus project spurred on by CMS, Medicare, Medicaid. And we knew that we had to introduce some type of behavioral health integration into the practices. We were in the process of hiring what is now a group of about 28 behavioral health consultants. And these are individuals who are master's level licensed for practice, who are now embedded across about 60 primary care practices in this newly expanded network. At the same time, we were struggling with things such as screening, which was getting done in the old-fashioned way. Some of it was being driven through electronic medical records as we shifted to using Epic in our core university practices, and that has continued to spread out to our suburban practices. But There was never enough time or room to cover all that we felt we needed to cover in screening and make sure it was brought back into care. So we returned to NeuroFlow and said, while postpartum depression was a critical issue in our OB-GYN practices, let's start talking about primary care. And that's where our use started to take off. I think we could go to the next slide there, Daniel, and continue to talk about this implementation process, which took on some unique characteristics with us that was a little different than the way NeuroFlow had worked before. And if there's time, Will could say more about that. But we decided to go with a model where we would bring in a platform like NeuroFlow, which would be both web-based as well as iPhone-based, where our patients could go in and get support services, they could get screening, they could have monitoring as frequently as we prescribe, they could do journaling and a host of other activities. But we didn't want to just send an invitation to a patient without a direct connection to one of our clinical staff. And it isn't always done that way, but that was our way of doing it originally. So that our behavioral health consultants in these practices were usually the ones to put the invitation out there to a patient and then monitor the activity. In some practices where we did not have a large BHC presence, the physicians or nurses opted to do the same thing. But from a Jefferson practice perspective, we didn't want this going on unless there was someone in each local practice who took responsibility for the interface with NeuroFlow. That slowed things down a little bit, but in the long run, it secured the way this tool was used. And I think it helped with a lot of the results that we began to see in terms of integrating the information that was available and rich on this platform back into the practice. So you will hear of other apps where you can just go to the web and sign up. And I'm sure some of you, like me, use some of those things. My use is intermittent, especially the one for weight control. But if I had someone connected to my primary care practice who knew I was using one of those apps, I think I would probably be more diligent about working with that. And so that's the pattern of use we have had primarily in Jefferson. And now we're starting to experiment with a few other models. Another reason we went with Health Partners was that they were very flexible in designing things with us. So we would look for particular screens that related to specifics in the practice, whether it was around diabetes or sleep disorders or other kinds of things like that. And it's fairly easy to make sure that there were support programs built into the app that the healthcare team could recommend to a patient for follow-up. And then there was also feedback to us about how much these devices were used. We have used that also with our electronic health record, and that's been a slower transition, not so much because of NeuroFlow, but because of the complexities of bringing information into the record and making sure it is then distributed across the practice. So we are fully integrated now in our what we call our center city university-based practices, and we are now emerging in our suburban practices where their electronic medical records are also smoothly integrating with NeuroFlow. So for instance, if I was assigned to do a GAD or PHQ-9 screening for anxiety or depression, my scoring now will find its way back into the electronic medical record. But that wasn't the case for the first 2+ years that we were working with it. That information would find its way back to the practice, and it would usually go to the identified individual in the practice to receive that information that could be a behavioral health consultant, or it might be a nurse manager, or in some cases, our physicians themselves wanted to see all this information directly. So that's how we began with NeuroFlow, and that's how we're currently using it. It's flexible enough that we're still looking for new opportunities to design it and move it in new directions. Coincidentally, and our next slide, I think, shows this. In the background, our practice management group that is constantly mining data and looking at performance, more often with a view towards how we're doing with incentives, whether they're offered through the Medicare program or other insurers, decided on their own to study our patient population and look at NeuroFlow versus not NeuroFlow patients. And we were excited to see some of the results that you see here. And you can see that those patients who engage with this behavioral health tool actually started to do better in a number of ways. Certainly, we were able to track symptom improvement with regards to depression and anxiety. And we also saw a reduction in symptoms. But these results we already knew ourselves just from our direct practice. We also knew that they were not only taking the invitation, so the process is you get invited as you would in many ways on your phone or computer, and then you enroll. And so we would track how many people actually completed the enrollment, but more importantly, how many people continued to use the platform in the ensuing weeks or months. And we saw that that was going well too, so we were pleased with that. Individuals could choose some of their own screening as well, which was a good sign. What we didn't know, which we couldn't see ourselves, was what our data group was tracking, which is ER visits. But there was a nice reduction in visits for this population, which proved to be very exciting. And you can see, especially Steve Klasko, our CEO, was very encouraged by this. He is constantly exploring and looking at internet opportunities to enhance our practice. So all in all, this has been a nice development for us. We have found this a very useful tool to have in our hands, and we're starting to explore new ways to work with this. So for the takeaways, next slide here. We have certainly found that the digital behavioral health platform has expanded what we're able to do, and we apply it in different ways. It's something that we can customize. The timing of it is determined by the local practices. We don't push out any directives on that. The key is that it's accessible and it nicely supplements our traditional practices, which are very diverse practices that spread across the whole Philadelphia and New Jersey, South Jersey region. I think we find that these tools certainly can improve care, and our patients like them and enjoy using these things. And that it's been easy to integrate them into primary care, a little harder to integrate them into the record itself. But those are local unique issues to our Jefferson system and to our electronic medical record systems. We still feel pretty strongly that it's better to have advocates or liaisons within clinical settings if you're going to use this tool or any other tool. I think it makes for a more robust conversation in the practices. It increases the likelihood that activity that's going on between visits is incorporated into the care plans. I also think our patients appreciate the recognition that they're working with these things and their practitioners or their doctors and nurses are also using them and they're partnering together in making this happen. And as we continue to integrate across the electronic health record, I think this will be even smoother. In those preliminary sites that we've used, they're already able to look at ways of tracking symptom improvement. They're able to also look at opportunities to bill for some of the time that goes into using this device and bringing it into some of their conversations that are taking place there. As for next steps, we're also considering how to move this to our, let's say, employee, faculty, student, house staff population. So that's the next slide. We have actually rolled out now to at least 29 sites. So we're in pretty good shape in meeting one of those goals there. But a more ambitious goal is how to use something like NeuroFlow to help our employees and faculty, house staff and students with their needs, some of which emerged more strikingly during the pandemic, and which aspects of this platform will be of highest interest to them. We've done some testing of this with groups of employees, and one surprise we found was that while they were very active in using the different screening tools, one that we didn't anticipate, for instance, was that they were screening for pain. And so it hadn't really occurred to us that we needed to pay more attention to pain levels that were in our normal, healthy workforce. And I'm sure we'll see more examples as we introduce more things into the platform. So by the next few weeks, we're going to roll out NeuroFlow across 35,000 plus employees. Last month, we rolled this out to close to 1,500 house staff, residents, and fellows. And we also rolled this out to about 9,000 students in our university. And the students and house staff were very quick to pick up on this. The information is too new and raw for us to begin to interpret it, but we do know that they're enrolling and they're following up, which are all good signs. So I think our audience, whether they be university-based or clinically based in our practices or our employees, are finding that these tools enhance the way we serve them. And we're looking forward to seeing what new uses we are able to put this to in the future.